I am going to go ahead and get started. We are recording this, so if you don't want to be recorded, you can go ahead and exit. We do share this on our Canvas site. If you have struggles getting onto the Canvas, please reach out to Early Echo at usu.edu, and we'll help you get set on that. As you guys know, I think I told last time, for the new people that don't know, the Center for Persons with Disabilities has changed our name, and we are now the Institute for Disability Research, Policy, and Practice. Still have the same goals and feedback, but we have a new name. As you all know, the ECHO is an interactive community, so we really want to encourage everybody to be engaged, ask questions, provide any feedback to the case. If you have a case narrative that you want to share and get information, it's a great way to learn and gain further knowledge from our colleagues. So please reach out to us if you're interested in doing so. Once again, just remember that because we are dealing with some confidential information, please please always just avoid using real names, any identifiers, de-identify any examples or situations, and of course, reach out to any of us if you are unsure. All of our hub members have an asterisk in front of their name. So if you have any questions, you can reach out to them or reach out to Early Echo, our email, and we'll be glad to answer those questions. We would love it if you would rename your profile picture with your name, your state, your organization, as well as your occupation. If you get an email or a chat from me, it's meaning that I'm missing some of your information. So please respond so I can track that in our database. It's where we get the money to be able to provide these resources for free. If you have to raise your hand, you can do that by clicking the participant and do raise hand. You can always register for the ECHO sessions by emailing us at earlyecho@usu.edu. Once again, if you want a certificate of attendance, we need you to fill out those ECHO session surveys that come out at the end of each section. Canvas site, again, is where we store all of our recordings, any PowerPoints, any information from the sessions. Go on that. If you haven't been able to get on that, please let me know, or also reach out to Kurt Phillips at usu.edu, and he can help get us on there. Case studies, just another plug. It's a great way to gain information, hear from your colleagues. So if you are interested in sharing a case that you're struggling with, or one that you just want to keep learning more about, please reach out to us and let us know if you're interested in that. So REDCap is the email that should have the surveys. If you're struggling getting those surveys, always check your spam or junk email folders. We do have Facebook and Instagram posts, pages that if you want to share or follow us, please do so. We try to make sure that we put information about the sessions or any relevant information. So with all of that, with no further ado, I am going to turn it over. I'm going to stop sharing, and we have Megan Shelly, that is our presenter today. She is an occupational therapist, and I'm going to let her just take it away, and she'll.
Awesome. Okay. Can everybody hear me okay?
I can. Yes, you are
okay.
Good.
Perfect. So I am so excited to be here with you guys to share a little bit about constraint-induced movement therapy. It is definitely a practice that's near and dear to my OT heart. So I'm happy to get to talk a little bit about that today. So let's see. A little bit about me. So I am an occupational therapist for Primary Children's Hospital here in Salt Lake City, Utah. I've worked some in both our inpatient hospital and outpatient rehab settings, all in pediatrics. Currently, I'm doing just outpatient setting. In that setting, it's been really fun. I've had the opportunity to create and implement a constraint-induced movement therapy camp intensive groups that we've run over the past 7 years. Serving a variety of kids ages 2 to 14 in those groups, and then to do a lot of one-on-one casting and constraint therapy with my patients as young as 6 months all the way up to, I think the oldest I've casted is around 18 years old. And then with those camps, I've had the opportunity to present at AOTA National Conference when it came to Utah a couple years ago on some of the data that we collected for pre and post test outcomes with kids participating in our constraint camps, which was really cool to see. So I know I'm talking to a variety of different caregivers. This will obviously have an occupational therapy bias to it since that's my field of expertise, but feel free to ask any questions or reach out if there's links that would work for what your lens is and how you're working on things. So let's see. You guys probably were all able to see the learning objectives ahead of time, but my goal for all of you is that you'd be able to recognize patients that you're working with that would benefit from constraint therapy and be able to identify maybe what setting, what variation, what duration of constraint therapy would be beneficial for them. And then if your practice area is in OT in particular, to be able to apply some of these treatment ideas and interventions from constraint therapy to help your patients with that. So starting just with some background on constraint-induced movement therapy. So the very first studies looking at constraint therapy were done in Germany by a scientist named Monk in the early 1900s. And he was looking at primates that had had some sort of event where they weren't using one of their limbs as much as the other. And he was looking at if they forced that use, if they would use it more. And lo and behold, he found that that was the case. So studies kind of went further by Dr. Taub and his team out of Birmingham, Alabama. They are the ones doing a lot of current research and have set a lot of the standards of practice in this area. And they have looked a lot at constraint therapy in pediatrics as well. So if we're talking about constraint-induced therapy, there is an injury or an insult to the brain, this idea of learned non-use often develops, which then creates further motor planning, functional use deficits in the impaired arm. So we'll look at that theory a little bit. So you can see in this picture that cycle of learned non-use. So in the pink is whatever your initial injury is going to be. And then you can see how, if it's in that region of the brain, it's going to lead to some upper limb weakness, which makes movement harder, which then leads to less movement, which then leads to less success when people, particularly kids in this instance, are attempting to move. And then you're going to get that negative feedback, whether it's pain, failure, things are trickier, frustration, which leads to a compensatory behavior, a different motor plan, or you're using that other side a lot more to compensate. And then that leads to less overall movement in the impaired arm. And that leads to what we would call that learned non-use, that cycle that keeps going of this is hard, it's difficult, I get negative feedback, so I'm going to incorporate that arm less, and now I actually have less ability and less motor pathways on that side because of that if it continues for a long enough time. So the really exciting and cool thing about that is that there's a ton of research showing that constraint therapy demonstrates the greatest impact on spontaneous use of an affected limb after an injury, which is really cool. So, constraint therapy in and of itself is going to have a couple principles that need to be followed for it to be categorized as true constraint induced therapy. So, there's a really strong focus on repetitive, structured practice through intensive therapy. And we'll get to what intensive looks like and what that duration needs to be in a couple slides. But focus particularly on that affected upper extremity. We're using restraint of some form for that less affected arm. And then we're really trying to use that principle of shaping. So oftentimes this is our therapeutic use of self, but we're giving strong reinforcement to target a specific behavior, motor plan, movement, with each successive movement and feedback that's getting us closer to the desired behavior that isn't currently existing. So we're taking, maybe we really, really, really want to get this child some active supination. And we're going to pick a lot of activities then that work on getting to neutral. Can we go a little bit past neutral? Can we help do an active assisted stretch into supination and then they maintain it? And we're providing a lot of feedback and a lot of directed activity towards that specific movement during restraint times. Modified constraint-induced therapy you might have heard of and is often applied more frequently to that 3 and under crowd, but it's typically referring to less intensity with restraint or practice time, or a less intense method of providing that restraint. And it's more often used for infants or really young toddlers because it feels less invasive and less stressful often for families. So originally, constraint therapy was first studied and created with the population of adults following a cerebral vascular incident. Later on, as they started to see really wonderful results and were wondering how this could be applied to more patient populations, it was started to be used a lot more with the pediatric population. So groups of kids that it's most typically used with are children that have had a traumatic or acquired brain injury, kids with cerebral palsy, after a hemispherectomy, kids with a brachial plexus injury, or after a stroke that's happened later on in life. The main difference for especially our patients that we're seeing with cerebral palsy or a birth brachial plexus injury, if you think about it, these children never have had the motor capacity or the ability to complete these movements typically, because this was a birth injury, versus for adults who this was originally created for, they've had a lifetime of opportunity of being able to have that skill, and now they're trying to relearn it. So in some of our patient populations in pediatrics, we're really working on an initial learning of a skill versus a relearning of a skill. And research has found that that is still really effective, even for a new skill, not just for regaining skills that have been lost. So best practice age range, the majority of research in the past has been based on looking at doing constraint with children 2 and up. However, as we know, and you guys know as early intervention practitioners, the brain has a ton of change in the first few years of life. It's typically at about 80% of its full size at age 3 and 90% by age 5. So definitely those 5 and under years are going to be our most naturally formative and changing years in the brain, which tells us that that would actually be a really wonderful time to be doing an intervention like this. So there's been a lot of new research coming out in about the last 10 years that's looking more at what they would consider baby CIMT. So in 2015, they did a retrospective study that looked at the hand function of 2-year-old children who received what they considered baby CIMT. And then children who did not receive that intervention at all, they got traditional therapy. And the children that received baby CIMT were 6 times more likely to have a high functional level of use of their impaired arm at the age of 2 than the children who didn't receive the treatment. Additionally, in 2018, they've done an exploratory study looking at dosage of 36 hours in total, split into 2 periods of 6 weeks, where they had infants that were receiving a restraint on their non-affected hand for 30 minutes a day with therapy during that time. And they compared that to a group of infants of the same age that were receiving what they called baby massage. And the children receiving baby CIMT showed a significant improvement in their unimanual abilities, looking at it on the hand assessment for infants in comparison to the baby massage study. And that was looking at 3 different groups. So it was infants that were 3 to 4 months old, 5 to 6 months old, and 7 to 8 months old, which gives us some really great data on that under 1 populations, showing us that it can be really effective for helping in those early years, and that children are able to tolerate it even at a pretty high intensity. And then finally, they're doing what's called the Baby Champ study right now. It's a randomized control trial that's coming out of Roanoke. And they're still recruiting for that study currently, but they're looking at infants 6 to 24 months old with a cerebral palsy diagnosis. And they're going to be doing 3 different groups of 1 with therapy in a cast, 1 with therapy in a splint, and then 1 group that's just getting intensive therapy without any restraint. So if you have any patients that you think would be a good fit for that, I can try and connect folks or give you the information for the study if you have any families you think would benefit from that. And that is a 4-week commitment, 3 hours of therapy per day, which I'm excited to see the results of. So looking a little bit more into practical application of things, there's a wide variety of constraint-induced therapy restraint options. So you can see there's a variety of pictures here. The most frequently used, I would say, is a hard or a soft cast. So that's going to be the little girl with the purple cast on. Soft cast still looks like a hard cast. It just can be taken off by parents without a cast saw. So it can be a really good option for some of those younger kids that it might be kind of traumatic to have to use a cast saw. You can also use a sling. That's typically going to have to be with a child that's older, cognitively intact, is bought in and willing to keep the sling on, because it's going to act as a reminder not to use that arm, but it's not going to obviously really impede them if they decide that they want to use that side. Additionally, sometimes folks will use an ACE bandage, wrap it to an arm or a stomach, a PD wrap or a no-no. You can see the little guy in the corner. Obviously, we would just use 1 if we were doing restraint, but that can be a good option during therapy sessions or for home programs, because it's pretty accessible to families to take on and off. Sometimes people will do a bivalve cast, which is that green and purple one with the straps. So that would involve casting, you cut it and then form it so that families can take it on and off. That's typically used when families are doing this as a home programming option. Sometimes older kids will do well with like a glove or a mitt, or really young babies can do well with that as well. And then you can see that top right picture is somebody made a splint and then they're doing a sock over it. So there's really a lot of options out there for doing more of a traditional constraint or even a modified constraint therapy. So one thing that we really consider with this is what frequency, intensity, and duration is needed to really get the best bang for your buck with this. So a variety of studies have been done looking at this as well. So they looked at a retrospective study of a variety of studies over the 1999 to 2005 time period. And that looked at 15 weekdays with weekends off being just as effective as 21 consecutive days in a row. So essentially a 3-week time period, but giving some little breaks over the weekend. And that was really encouraging to me as a practitioner, that even a little bit lower intensity with some breaks for family to give that buy-in was equally as effective. Additionally, they looked at in 2006 and 7, 3 hours a day for 10 weekdays versus 15 weekdays, 6 hours a day. So 5 extra days, double the amount of therapy on those days. And same thing, they found pretty similar effectiveness and functional gains when comparing the two groups. For people that are doing early intervention in home therapy, I found it really encouraging. So clinic-based therapy was found to be pretty similar to home-based. So as long as caregivers are trained and bought in on what you guys are working on, they've found that it can be just as effective in a home setting as coming to therapy in a different location. And then in 2012, DeLuca completed a study looking at what they considered moderate intensity. So that would have been, that group was getting 3 hours a day for 21 days versus high intensity. And that group was getting 6 hours a day for 21 days. And they found, again, that there were the same positive effects with significant gains being maintained when they looked at post-test a week after having the cast removed and a month after having the cast removed in both groups, both moderate and high intensity. Anecdotally, the constraint camps that we're running are typically a 3-hour-a-day therapy chunk, 2 times a week over a 2-week duration. So kids are keeping their cast on for about 12 days typically, and they're getting 12 hours of in-person intensive therapy with an expectation of a minimum of 1 to 2 hours of home programming aside from that on other days. They're also looking, there's a current study looking at I-Acquire programming, which is out of the University of Alabama, Birmingham. And their recommendation for constraint for infants is offering 3 hours a day or 6 hours a day, 5 days a week for 4 weeks. And that was looking at infants 8 to 36 months of age, so all in that under 3 category. And they're working on that current randomized study right now to see what the benefits are in variation between the two groups. However, looking at all of that data that's been collected in the past, I would say takeaway as a practitioner, somewhere in that range of about 3 hours a day with 3 to 4 weeks of weekdays would be considered from the research optimal timing. Like I said, our constraint camp doesn't work like that with insurance and billing and scheduling. And we've had awesome results in a shorter window of time with less in-person therapy than that like gold standard. So I think there's a lot of different ways in which you can be applying this to your practice and having families follow through that are still going to have a really great benefit for your patient. So thinking about all of that, some of the contraindications or concerns when you're thinking about whether or not a patient would be a good candidate for casting, we always want to think about their fall risk. So a lot of those younger kids might have some motor delays already based on what they have going on, or are using some adaptive equipment for mobility. Definitely not a no-go if that's the case, but really being super cognizant about that fall risk. So especially during casting, the weight of the cast typically will shift balance enough that kids are a little more likely to fall. It also is obviously taking away their arm that most kids will typically use for their protective reaction if they're falling. So thinking about those things, thinking about how on top of it family and parents are going to be and how able they're going to be with managing environment are all going to be a consideration for whether or not that child would still be safe to participate. Down that same vein, I would typically say to avoid if you've got a child that has unmanaged seizures for the fall risk concern, but also a lot of studies have shown how much brain change happens during constraint therapy and new neural growth, which is a wonderful thing. But for some of those patients that are having a lot of seizure activity, increased brain activity can be linked to that increased seizure activity. And so they might not be a great candidate during that time. Um, Along with that, any open wounds, sores, major skin concerns on the arm that's going to be casted, we definitely don't want to cast over anything that's an opened wound because that will typically get worse if it's under a cast. Really considering your patient's behaviors and their impulse control. We had somebody cast through our clinic, a 12-year-old that had had a TBI, and his mom walked in and found him trying to burn his cast off over the stove over an open flame. So really thinking about their ability to manage having a cast on, and if they're older, if they're going to be able to manage that safely. And then lastly, being really cognizant about where your patient is at developmentally. So as we saw, constraint can really be done across the age span, and there isn't a specific window or time period that we think, man, this is the only time that it's going to be effective or improve things. With that, if our kids are already motor delayed or having some developmental concerns, if they're looking like, oh, they're just about on the cusp of walking or crawling, or even sometimes if it's in a different area of like, man, they're starting to get a ton of words right now, or anything like that, I typically recommend that families wait until that skill has emerged and been at least moderately cemented, and then to do casting after that. The reason being, typically you will see not a ton of progress in other developmental areas during an intensive bout of constraint therapy because kids are so focused and putting all of their energy towards that one area of change and development. So that can be really beneficial to have that conversation with families. If you have casted or you have a more permanent restraint on, you want to make sure that you're watching for any skin swelling, skin discoloration, odor, or if you're getting any poor capillary refill in fingertips and thumbs. So anything longer than 3 seconds, I would take the restraint off and be concerned about. With that thought, I'm just thinking about it. We're doing camp right now, currently this summer, and one consideration, if you have a lot of flexibility and time, is to think about temperature and heat and season. So if kids are keeping it on for an intensive period of time, particularly in the summertime, casts get hot. And so a lot of kids will have more itching and discomfort because they're sweating and it's getting stuck in their cast. So if there's flexibility to do it in the fall or spring, sometimes that's a nicer, just more comfortable physically time period for kids. So some of the studies that have been done, and this was out of University of Alabama, Birmingham as well, looked at what the optimal inclusion criteria would be. So if you're looking at your patient and you're thinking, okay, with the functional skill set and movement they have, would they be a good candidate for this? These were the guidelines they created. So they were saying having 10 degrees of active wrist extension, thumb abduction, and at least 10 degrees of active extension of any other 2 digits of their impaired hand. Limited spasticity, so 0, 1, or 1 plus on the Ashworth scale, again on that affected hand. A minimum of 45 degrees of active shoulder flexion and abduction, and a minimum of 90 degrees of active elbow flexion and extension. Adequate balance, like we were talking about, minimal cognitive dysfunction. So I would look at this and say, this is a great gold standard. If you have a kid that fits in this or has more skills than this, 100% would be a great candidate. With the caveat, I have casted a lot of kids that have significantly less movement, more tone, or a little bit more cognitive dysfunction than this is categorizing, and still seeing them make a lot of gains from where they're at. So this is just a nice guideline, but absolutely kids can benefit from constraint therapy, even if they have less active movement or more tone than this is indicating. So looking at some of the outcome measures that are available for us, there's a good deal that's used, particularly within the OT field, to look at this, but some of these move over into other therapy domains as well. So the box and blocks and 9-hole peg test are both like fine motor dexterity tests. We can look at grip and pinch strength using a dynamometer. We can also use the Able Hand Kids, active range of motion and passive range of motion, manual muscle testing, the goal attainment scale, the pediatric motor activity log, and the pediatric arm function test, inventory of new motor activities and programs, the quality of upper extremity skills test, the Bailey, and the mini assisting hand assessment. These are kind of the main ones that are used currently to look at pre and post test data. The GAS and the Able Hand Kids are both more of a subjective measure. They're not standardized. Parents are going to have to help report with that, but they can still be really useful looking at functional skills. And then the PMAL and the PAFT are both out of UAB. The PAFT in particular requires videotaping and some additional training to be able to score. And that's looking at a variety of different motor tasks that they then review, and they score on the amount of use of their impaired arm and the quality of use. And then the QUEST is looking at, there's 36 different activity items that they look at, and they're focused on assessing grasp, weight bearing, protective extension, and ability to dissociate movement on that impaired side. And then they're rated on their function, their spasticity, and their cooperativeness. And that can be used with children 0 to 12 years old. So obviously there's a large range of activities we can do, particularly based on what movement patterns a child really needs to focus on. But typically we're looking at really play-based activities that are based in the child's natural environment and have relevance to their daily tasks. So we want a child to get about 70 to 80% accuracy with a task. And then once they've achieved that without compensatory movement strategies, we're going to start to withdraw support and increase that challenge. Going back to that shaping principle, it's really our job to provide adaptive and quick feedback to help shape that success and start to break that negative feedback that's happened in that learn non-use cycle. Activities that I'll typically address and have families work on during their home programming in this time: tons of ADLs, as much self-feeding, dressing, undressing, toileting, grooming as they can manage. Lots of manipulative games depending on level of function, but tasks that are going to help to encourage more active grasp and release, controlled ability to release in a specific size object or placement, working on pinch, finger isolation, in palm translation if they have really high functional hand use, lots of weight bearing, reaching, shoulder strengthening, elbow strengthening tasks for more distal control. And then a lot of times we see a lot of deficits in the areas of wrist extension, supination, and thumb opposition for kids that have a little bit of increased tone. So doing a lot of activities and games targeting these movement patterns. So some really cool data has come out. They've looked at using structural and functional MRIs to assess changes in the pediatric population when doing constraint therapy. So Taub in 2010 looked at using a structural MRI pre and post test, and they found pretty notable neural changes in gray matter following therapy. Um, and they had looked at, there were no significant changes the 3 weeks prior to intervention. So they were really pretty sure this was based on solely the constraint intervention. Kids weren't having other issues going on. And they also found cortical reorganization occurring. So that size of the affected upper extremity representation in the brain had increased after constraint. And both of those gains, so the increased size of representation and the neural changes in gray matter, were maintained completely when they did a 6-month post constraint intervention without any other like additional therapy intervention between that time period, which is such a cool finding. And then Zhao in 2012 looked at a functional MRI and found that the activation volume in the affected sensory motor area was significantly different after 3 weeks of constraint therapy. Brain lesions had decreased, and there were new activated areas, predominantly in the supplementary movement area, the premotor area, and the ipsilateral sensory motor area, which again is really cool, essentially showing us there's a lot of pretty significant brain change in a positive way occurring with constraint therapy. And that's being maintained over time, even without continued constraint therapy. So on that same boat, and we can skim some of this, but there's a lot of supporting literature looking at this. So AOTA 2020 put out their practice guidelines that they do every few years, where they look at a large variety of practice areas. So looking at their birth to 5 practice guidelines, when they were looking at what the most beneficial therapy was for an upper extremity impairment, constraint-induced movement therapy was the only intervention that got what they would consider their A level of rating, where it's the most effective, had the best research, had the best data supporting it, and maintained the best functional gains for patients, which I think is pretty incredible. And as practitioners, we really need to be talking about this with families and implementing this more, even with our under 3 population. So along with that, you can see a couple more of these studies. So they were looking at kind of that duration of effects. So Taub and DeLuca have both done studies looking at the immediate effects and then long-term follow-up. Both of those studies found that the long-term effects maintained from the initial gains, which again is really cool. So we're not seeing a lot of families ask me or have concerns. Great, they're going to use that side more while they're in a restraint, but how is this going to actually apply to their functional use and the maintenance of this skill once we take the restraint off and they're able to use both hands again? Certainly, I think you'll see they're going to go back to their preferred arm, and that's still going to be their dominant arm, but bimanual skills increase a lot, and we're seeing improved motor planning, awareness, incorporation, use of that affected side as in relation to pre-constraint therapy. And you can see too, out of Children's of Alabama, they found that constraint therapy was 2 times more effective with the gains that they got than traditional upper extremity occupational therapy. The last 2 that I think are really interesting. So DeLuca had a study come out in 2020 that looked at providing multiple rounds of therapy for pediatric patients. And they found that the most intensive gains were found the initial round of constraint therapy, but then they still found notable and promising gains. They looked at 3 rounds of therapy occurring over a couple month period where the patient would do a round, take a break for a month or 2, and then do an additional round, which I think is really promising too. So even after an initial intervention of this, patients can still be good candidates over time for participation. Okay, so I think I'm right about on time, and I'd love to talk about any of that or answer any questions that you guys have.
So Megan, that was great. And I think somebody was coming off of chat, but there were a couple of questions about the study and who could they refer a child? How do they refer a child for that?
Oh, the CHAMP study.
Yes, I believe so. Mm-hmm.
Let me see if I can look up real quick. I believe that I've had, if you look up Baby CHAMP Roanoke study, they have a website and it gives the information that you can provide for a family that they can contact the study providers and see if they would be a good fit.
Could you throw that in the chat there, Megan? Just
Yeah,
the
let me see. I'm
the
going to
name
see.
of the study or whatever.
Yeah, let me
Thank
see
you.
if I can find it really quick for you. Or the chat. Nope, I did something. Okay, remind me how I can get to the chat. Sorry.
So there's a button on the very bottom of your screen and it says chat.
Wonder if it's because I'm sharing my screen that I can't see it.
You can certainly stop sharing and see if that is allowing you to.
Okay. Let me see. Oh, sorry. Okay. Let me get it.
And if it isn't, you can just email it to me and I'll send it out to everybody too.
Okay, perfect. I will do that. Sorry, I was trying to get, I can find the specific page and I'll email it to you.
Okay, perfect. Then a couple of other questions. One is asking, has insurance covered this in most instances?
Yes, so I would say depends on the circumstance, but with the constraint camp that we're doing, because it's multiple children, that is a out-of-pocket cost for families, but the cast is still typically covered by insurance. When we're doing just one-on-one therapy with a child for constraint therapy, I've never not had it covered by insurance.
Okay, and then another question is from Crystal, and she is asking, she says, I've heard a family describe their experience with restraint therapy as negative because they felt that their child's abilities that they did have were being taken away. How would you explain what you were going to do to a family to help them feel more comfortable?
Absolutely. I think, and it's hard for families sometimes, they sound like they would be maybe a family that would be good to start with a shorter period of time of doing it so it doesn't feel so overwhelming and intensive. But I think helping them to see the big picture, in all of the research, they've never found that children have like decreased skills afterwards or decreased use of their stronger side. As soon as the restraint comes off, they bounce right back in terms of using that functionally and effectively. So I would look at it as, you know, it might be a really difficult 10 days where you're committing to this occurring, but I think the benefit you're going to see at the end of that in most circumstances really outweighs the discomfort over that period of time. And because kids are so smart and adaptive, for some of them, if you don't use a restraint, it's really difficult to promote the amount of shaping that we want on that impaired side, because they're just good at using other compensatory ways or moving around and getting out of it.
I have a question.
Yep, go ahead.
What does your success look like with helping families like follow through on the strategies at home?
Mm-hmm.
What is that? And I loved your activities, like these are functional activities, that type of thing. How receptive are parents in that follow through, and how have you kind of set that up?
Yeah, so I think if you have the ability to do some phase of intensive therapy with you during that time period, it helps a lot for both encouragement of families, but also that follow through with like, how is this actually going, doing it at home? Overall, I've found that families do way better than their typical home program, because every time they look at their kid, they have a cast on their arm and they think, oh, okay, I have to do that thing that Megan talked to me about. It's on. Okay, this is kind of irritating for our life. Like, let's make the most of it if we're going to do this thing. And we talk a lot about ahead of time, like, let's pick a period of time that works the best for your family. Like, when can you have additional support? When is it going to work that maybe if you have other kids, they're going to have some support too and be occupied, so that you can really try to focus this time on your child. In that same regard, I have found really like 2.5 and up, those kids want to do their own thing so much that they get so much therapy because they just don't want their parents to do everything for them. So they're getting, hours that they typically wouldn't of therapeutic intervention basically to themselves, because they're like, well, I'm going to figure out how to play, and they do it with their cast on.
Great. The other question is just talking about, it makes sense as far as giving an initial large dose and high frequency. So how would you implement this in early intervention? Would you encourage parents to continue outside sessions or just during weekly sessions?
So I think that's a great question. I think this is really going to depend on your read of the family situation and caregiver situation. If you feel like it's a family that can really implement at home, they might be a good candidate for casting. That you feel like, okay, I'm only going to be able to come once a week, but they're going to be able to continue to implement this and maintain a lot at home. If it's a family that you feel like, I'm not so sure, they might be a better family to start with a less intensive restraint, like a Pediatric or something that they can have on during your session. And then you say, hey, I'm going to give you these specific activities. Let's try wearing this for 30 minutes a day for a week. And hey, if we can do that for a period of time and you feel like it's really effective, I would love to move forward with something more intensive. But I think trying to find that read on a family, I think I would say minimum of once a week in person if you're trying to do an actual cast or something like a more intensive would be, I think, really necessary in order to help check in with family and patient and make sure that things are going well. But I think with the right family, once a week would probably be an okay fit.
I have a question about dosing. So you had given information on the infant study, so the less than 12-month-old, that was 36 hours divided by 2 sessions. So if I did my math correctly, that's about a half hour a day, which is what I've done with babies. But then you had your takeaway of 3 hours a day for 3 to 4 weeks. And I didn't see an age on that, but I've got a child that's just turning a year old this week. And they did a couple of 6-week sessions with that 30 minutes a day. when she was really young. She had a moderate MCA stroke, and she's just done fantastically. But now that she's learning to walk, we're just seeing really subtle posturing. Like when she crawls, we're just seeing a little bit of finger curling on that side. And she's just a little slower to learn to point. Usually she just has had a weak lag with her involved hand, but the pointing just hasn't come along like earlier skills have. So we're talking about revisiting CIMT, but I'm just wondering what kind of dosing, because going from a half hour a day to 3 hours a day is a pretty big change.
Yeah. So the 3 hours a day is looking at a little bit older age group. So I want to say that was like 4 and 5 year olds at the youngest. So I would say at that age, 30 to 60 minutes would probably be a great dosage depending on what she can tolerate. But I think if you can bump up a little bit, that would be great at that age. But even 30 minutes would be awesome.
Thank you.
Okay, well, Megan, thank you so much for your time. And if you have any questions, please don't hesitate to reach out to me and I'll get those to Megan so we can connect each other. I am now going to turn it over to Sean Maurer. He is going to do our case presentation and then we'll do breakout groups.
Perfect. Thanks so much, everybody.
Thank you, Shelly.
Thanks. Megan's information was great and very timely for the case study that we're going to do today. We've got 3 therapists that will be kind of sharing a little bit of this presentation just because when we looked at this little girl and the appropriateness of her abilities and being able to do the casting for her, we looked at it with a very global approach. And so we've got a PT and 2 OTs that have been working with this little girl. And she's done really fantastic. So let me bring up a little bit more information. So just to introduce the other therapist, Tara Kolowich, she's one of our occupational therapists. Michelle Kerback is one of our physical therapists, and we're all with the Jordan Child Development Center program. So we've been doing casting. I've been doing casting for quite a long time. It's a really awesome way to get that function from kids and see their growth. I think like Megan was talking about, especially with the family that we're going to present today, you got to look at the individual family circumstances quite a bit and really make decisions that are going to be best for the child and family both, because the families are going to be the one left with the child with the cast on. And if you're doing intensive casting, that child's going to have that cast on for a full 24 hours a day. So you start to think about the routines that the child's going to go through, bathing and feeding and all of those things, and how to intertwine your routines in with that activity and just making the most of all of those daily activities. So when we look at this little girl, she's over 3 now, and I think we did 6 to 7 rounds of casting with her total. And this was an excellent family. They jumped in with both feet first on this and were willing to do the activities at home. We had a really involved grandparent too that babysat, and she also took over and did a lot of this therapy with the kiddo on a regular basis. So that's kind of just a little nutshell of why we started casting with this little girl. I'm going to let Michelle take over and give you a little bit more background and go from there. Are you on there, Michelle?
Yes. Can
Go
everybody
ahead.
hear me okay? Hopefully. So I'm Michelle Kerback. I'm a physical therapist with the Jordan Child Development Center. And just a little bit of background on this little one. So I did her initial intake, or her initial eligibility evaluation, when she was 5 months old, chronological age. So she was still closer to a 2 to 3 month old adjusted age. And initially the family's biggest concern was her feeding. She was on a feeding tube. And so with that diagnosis, she did qualify for early intervention services, but they were receiving home health, speech therapy, and I believe occupational therapy to specifically work on feeding. So they decided just to enroll in service coordination only at that time. So I did not, I picked her up on my caseload, but I did not see her until her 6-month review or her periodic review. And then at that time, we kind of dove more into regular therapy visits, but there was kind of a 6-month gap that we didn't see her even though she was enrolled in our program. So that's just a little bit of background. But anyways, this little one, like Sean said, she's now 3, so she's graduated from our program, but she was born prematurely at 30 weeks, 3 days due to preeclampsia. Her birth weight was 3 pounds, 3 ounces, so itty bitty. She stayed in the NICU for 79 days. She had that ventilation assistance, but then switched to the low flow nasal cannula for the remainder of her hospital stay. She did not have to come home on oxygen, so her lungs and cardiovascular system were cleared, but she did have, like I mentioned, that NG tube from her birth to December of 2018, so about the 6 months. She did have an original diagnosis of a grade 1 IVH, but they did upgrade that to a grade 2. And then what was interesting, so when I went back for her 6-month review when she was a year old, she had just had an MRI, and her MRI did show a moderate to severe stroke on the left side of her brain. They don't know when that happened. It was not originally shown on her head ultrasounds, so they are thinking it did happen a little bit later in her life. So they didn't know when that happened. So that was kind of a surprise to everybody. Thought it showed up on her MRI. But with that stroke, she did demonstrate the right upper extremity deficits compared to her left side. Other just background information, she did have pretty severe allergies to dairy, eggs, and peanuts. She was being followed by an allergist. Again, no respiratory, cardiovascular concerns. She did have the history of eczema, which was handled really well with topical ointments, but that was something we wanted to watch out for with the casting, just to make sure she didn't have additional skin breakdown, things like that. So, okay, go ahead, Sean. Family culture. So this is a white upper middle class family. She is an only child. Both of her parents work. Prior to COVID, she was going to daycare, I believe, twice a day. And then her grandma helped out the other 3 days while both parents worked. And then with COVID, both parents started working from home. Mom made arrangements to be at every home visit. And then mom and dad were at home on all of our Zoom calls over this kind of past year, and as well as grandma. So grandma was always there, both in person and during our Zoom visits. She was a super support for both the parents and this little one. And she was completely involved. She was very much that grandparent of give me things to work on and I will do it. So with that, this whole family was so wonderful. We as a team were not worried about the follow through of any of our therapy suggestions because like I said, they are that family that we give them something to work on and they went at it full force. So that was so wonderful. And that's kind of why this little one was such a good candidate for the constraint induced movement therapy because we knew we were going to get good follow through. So initially the family's concern, like I talked about, was her feeding since she was on the feeding tube and they just wanted her to be able to eat 100% oral feedings, which she did achieve that goal. And then, like I said, when I came back after 6 months, that's when we really noticed those right upper extremity wasn't quite matching up to the left side. So family just really wanted to work on that symmetry, getting her to use her right hand as much as possible. And I don't want to say she was completely neglecting that side, but she was getting close to that. She would just kind of keep her right arm tucked to her side. If we did, present something to her right hand, she would almost immediately pass it to her left. All of her reaching was with her left hand. So we really were starting to see those differences side to side. So family got pretty worried about that. So we just hit that head on. And then they also just wanted to make sure that she hit age appropriate developmental milestones in all areas. So of course we were focusing on the right upper extremity, but they just wanted her to crawl and walk and talk just like any other little one. So we kind of worked on a lot of different things as well, but definitely candidate for the constraint induced movement therapy.
And I think too, adding with that, this little kiddo she was so motivated to do a lot of the things that we asked her to do that doing round after round of casting with this little one, it was very fun because I don't have very many kids that when you go to cast them, they just stick their arm out and are ready to have the cast put on. And she was one of those kids. So you couldn't have asked for a better kiddo to do it with. So Tara, you're taking these, aren't you?
Yes. Hi, I'm Tara Kolowich. I'm the OT, and I joined Michelle right around when we had that 6-month review, so right around her first birthday. And so these goals were kind of the latter end goals that we were working on. And like Michelle said, we did some testing at the end of 2020, December of 2020, and she did really, really well because we used the BDI, and it doesn't, that unilateral weakness doesn't really even show up so much, but we knew we wanted to continue the casting with her. So we weren't actually even seeing her the last 6 months, but the goals that we were ending up working on were, like Megan had suggested, that working on that grasp and release, and using even just the particular grasp that we needed for certain activities. So sometimes we would do like tug of war, and she would need more of a power grasp, and Dad was really good at watching and seeing some of the different tone that would show up in her grasp. And so we would work on using sensory bins and Play-Doh and puzzles, and dressing and feeding were big activities that we would use to help refine that grasp for her. Two-handed, another goal, the two-handed activities spontaneously. Like we said, she's just such a good, she just wants to do really well. So the verbal prompts were, she did excellent at those, but we were watching to see, when she was a little younger, will she just pick up a book and start flipping the pages? And boy, even when we were doing the Zoom visits, we just so appreciated the videos that would come in of her climbing up on an ottoman and grabbing a book and reading that to herself, and just doing so great with those two hands working together. And then the last one is parents expressed that they would really like her that she was getting very frustrated when she was undressing, kind of getting upset and just more moody than she usually is. So we would work on, again, using that shaping. And when the cast was on, we would just work on that strengthening endurance, and maybe having that sock almost all the way off, but her pulling it off until she could consistently do that. And then adding a little bit more challenge to that activity so that she could do that with less frustration and less assistance from her parents or grandparents. The barriers, like we said, this was a really ideal family, but they were both working, and she had a lot of different people in her life spending a large portion of time with her. So it was just getting everyone on the same page, especially with that daycare. Michelle and I would try and listen to see like how this could work. I think the biggest issue was maybe her, because she's such a good mannered child, maybe just getting a little ignored. And so, when would be a good routine to ask the daycare provider to really focus in on Addie and helping her. But I believe we weren't doing casting at that point. We'll get to how we started Addie with the CIMT. And then just the other was casting during COVID. We made it work, but obviously there was just some more concerns and considerations to take as far as when to do that casting. But we did end up doing it during that year, as we saw that it fit both our precautions and what the family wanted. So shortly after her annual review, we started just introducing CIMT with the family. And as some of you mentioned, there definitely are some reservations that come up, but we presented her with our protocols, and also I think Megan had mentioned the Eliason protocol that we found, or Michelle and I found that we used a self-adhesive wrap that was just 30 minutes a day. So such a minimal amount to ask for families. Well, I say that families have so much to do. So it's certainly something, but much less than when you're talking about casting for 2 weeks. And we did this 6 weeks on, 6 weeks off, and I believe we did that twice. And we created our own little outcome measure that we pulled items off of the help checklist, just so that we could show that she was making improvements after each time. And so the buy-in just kept on improving. And so at the end of that second round of the self-adhesive wrap, the family was ready to do that casting, which I believe happened in February. And then Sean, I don't know if you want to, I'm happy to, but Sean really has kind of refined our program's protocol.
I can speak to that real quick too. With our program protocol, we've used it over years and years of just direct use with families, and also using all of the current research. And so we've modified it over time with the research. And as I've done kids, 15 years ago up till now, it's been very interesting to see how it's become kind of the gold care, as what Megan said, and how it really, when you present it to a parent, if you can go to a parent and say, we can see 2 to 6 times better increased outcomes by doing this, that's something that I think any parent would really find valuable. And we've seen the increase with the kids that we've done. As with this little one, we started off with doing the 4 rounds of casting that were done during COVID. And we had some additional follow-up rounds after that too that we did, and found that with each round of casting, we saw that improved distal use with her hand. She was one that we didn't have to deal a whole lot with tone. Her tone was pretty minimal. She never had Botox, and some kids that I've casted, they've had Botox injections, and we've tried to do casting right after those Botox injections have been done to make the most use of that. And for those maybe don't understand the use of Botox with spasticity or tone, that Botox is used to decrease those, decrease that tone that's being over affected, and the child's having a difficulty time overcoming that. So by doing the Botox and then casting, compiling those together, we were getting some good results. With this little one, she didn't require any Botox because of her tone or anything like that. We did do with the parents and grandparents, talked about all of these routine times during the day, feeding, dressing. You have to look at with the cast, is a child going to get this cast wet? You have to talk to parents about keeping that cast dry, because if the cast gets wet, that can really cause a rapid demise of skin and tissue breakdown in the cast, especially if they have skin like this little girl that had a little bit of eczema too. Adding a wet environment and a little bit of rubbing in there can cause some big problems. So you got to think through all of those as you're looking at doing the casting activities. I always recommend to my families when we do it to get a good bath time cover. They sell them on Amazon and they're great, and you can usually keep the kids pretty dry with those. So with this little one, she followed the protocol pretty spot on. We did, like I think you'd mentioned, Tara, we're doing between 7 and 14 days with cast on, taking cast off for 7 days, and then starting another round after that. Some days, sometimes the rounds in between were longer, just depending on what the family had going. Reason why we kind of refined our protocol of doing it 7 to 14 days and then off for at least 7 was to minimize muscle atrophy of the good arm. We didn't want the kiddos, as some parents have concerns of seeing decreased use. While that we've never seen that happen, we have seen some just muscle mass decrease in the arm. So we wanted to minimize that. So that was kind of how we came up with our protocol of doing that 7 to 14 days on and then at least 7 days off. So yeah.
Yeah, and
also, oh, sorry, it's
go
Michelle
ahead,
again.
Michelle.
So just for her IFSP, she did have PT and OT services twice a month anyways. So we just kind of fit that into our schedule since we were seeing her every other week on a regular basis. And with the research that we had looked at, we felt like that fit in with kind of the schedule that we already had going with the family. So it worked beautifully.
Yeah. The other thing that helped us determine when we were doing some of that additional casting, so I think that original protocol is a series of 3 casts, but we would ask parents to really pay attention to, okay, how many days did you notice that she was using that that right hand in her case spontaneously? When did you start seeing that decline? So that was an indicator too of, first of all, for them to see, oh, this is helping a lot. Okay, this is lasting about this long. And we would see a gradual increase, and the subsequent casts were much further out. I would say, I don't know, Michelle, but I'm thinking like 2 months and then maybe 3 or 4 months that we were having a space in between her casts. So it was really helping, but those boosters of the casts would, we thought were very beneficial for her as well.
One thing too, with this little one, Tara, I just wanted to mention, she was a classic display of learn non-use. She was one that with that over time, without having to cast, you would see that learn non-use really start to express itself. And I think that's very common with a lot of kiddos with one-sided weakness like this, and you'll see it often. That learn non-use can be one of the biggest roadblocks. So the casting model really does help to overcome that.
And this is a perfect slide, Sean, but there was the activities that I kind of went into earlier, but I would just share my favorite activity when I was reflecting on her. They had 2 little, I think it was 2 little dogs, and they were front and center in their family. And this little girl was so motivated to interact with them. And when we were working on supination, we would help her hold the dog treat in her hand and feed it to the dog. And she was just so motivated to do that. And it just was fun to just work those different therapy strategies into her routines and things that were meaningful to her. So that was so much fun to come up with those activities for that family. And lastly, she has moved on. She's turned 3 in June. Sean was with me when we were talking about preschool options, and I mean, she is just
Smart little thing.
A smart little girl, just so ambitious. And so that we thought for sure pay for service preschool was her best bet. She would not fit in the preschools that we could offer her, and her BDR scores are there for you to look at. We had started encouraging them to make connections with outpatient services, and because they were seeing Shriners for her leg, they started making connections with OT and OT services after she turned 3. So they were hooked up, ready to go by the time she turned 3. And they are ready to take over that as needed in her future. So that's our little one.
You guys did a great job of presenting it, and it looked like there weren't really a lot of questions. So what I thought, and we are short on time, so I thought what we could do is just open it up to the entire group and let them ask you guys questions if anybody has had any experiences, or like, what would you do in this situation? So there were a couple of questions in the chat so it was kind of answered. I don't know if everybody saw that. So my chat is, so it says, does the family pay for casting, or is this included in EI services? Who pays for the casting? And Michelle answered that casting was not an additional cost for the family. They paid the monthly fee for PT and OT, and I believe our annual budget helps pay for the casting supplies. So,
We do with the families help with that, with the cost of the cast material. It's not that expensive, and honestly, it's a great trade-off for that little bit of investment to help the families out with that. So yeah, we didn't ever worry about charging families for that, but that's something that you can work out fairly easy if your program did require that. You know, I think contractually, private insurance, I think, is charging $75 to $80 for the cast, but yeah, you could figure that out pretty easy with your own program.
and so everybody can, if you have a question, you can just unmute, announce who you are, and go ahead and ask your question.
And we're open to any suggestions too. We're happy to take suggestions, questions, anything. So
I have a question. I've tried to use the PD wraps in the past, and the kids are super good at sliding them off. Any tips on that one, since we don't have a casting kind of service?
no, kids are smart and they do figure out how to get things off. We've used everything from the PD wraps to the no-nos to just about anything you can think of. Sometimes air splints that really squeeze tight to the skin can be helpful, and you can get air splints just on Amazon as well. You just have to be a little cautious with making sure you watch the skin in those cases and not use them for more than really 30 minutes at a time. But I think working with the families to find things that maybe will work. If you've got the kiddo that's pulling those wraps off quickly, you are getting used to that weakened arm, so that's a positive, but trying to keep it where they can do some other routine functional stuff can be tricky. And honestly, that's one of the reasons why we do switch them to a solid cast, is because if they're good at taking things off, they can be really good. I've had a little girl sneak off a whole cast in the middle of a shopping store, and everybody around this little girl looked horrified because she just pulled her cast off of her arm. And the parents were like, no, it wasn't for a broken arm, it's for something else. And so it was kind of a good laugh moment. But yeah, kids are great at taking stuff off.
Yeah, I would say the self-adhesive wrap, I can't think of the name of it right now, like Flexol or one of those. You can buy those at Walgreens or Rite Aid, Walmart, any of those. That works really well. This little one that we did the case study on, she eventually started figuring out how to kind of pick the end off. So we threw a sock on over that, and that worked really well. I've never done this with a family, but I've heard if a child, if it's colder season, winter season, if they're wearing long sleeves, you can actually kind of pin their sleeve down to the side of their body just with a safety pin. And that would be something that's pretty tricky to get off. So I've heard that trick as well. Or again, like a sling and just pinning the sling to their body, or wrapping the sling around with a pre-wrap or something. So those are other techniques. I haven't personally used them, but I've heard about those as well.
I was thinking too that because the one protocol is 30 minutes daily, and we would often, even because that's already a significant jump for some that could just take minutes or seconds to take off that whatever you use to wrap their hand, but often even just starting with like 10 minutes or less, and a really engaging activity, and just like call it good, make it successful, and really just work on that like high engagement. And then when she figures it, or he or she figures it out, like end the activity, and so that they might slightly be more motivated to keep that wrap on.
A couple other questions we're asking about getting the cast. We use this kind, it's called Delta Light, but you can find casting material on the internet, and Amazon sells it. What I would recommend is maybe speak to one of the OTs or PTs in your program and see if they have experience with using a certain type. We use this because it's fairly inexpensive, and we're used to using it and working with it. As Megan said earlier, when you put one of these casts on, you have an option to get it off, either use a cast saw or use a good pair of sharp scissors and a little bit of a, hopefully not a wiggly child. So it can be interesting sometimes to remove them. But we're using a cast saw. It is loud, but I think over the last few that we've done it, we found it's quicker. And usually if you can get the kiddos through that next 2-3 minutes to get it off, it's worth it. So yeah, so if you're interested in getting cast, I'm happy to share the type of brand that we buy, and could hook anybody up if you have a question about getting the cast material. So
Would you be willing to let anybody come and kind of watch how you do it? Because I mean, I worked primary as outpatient for a while, but they were older kids, right? So how the HUD do you cast a 1-year-old?
Takes a good team. That's why we had 3 of us often working with this little one. Honestly, it is something that it takes practice and should be done, through observation and doing it yourself. I don't know how many times I casted my own kids with expired cast to practice, and I'd recommend that's a good way to start, is if you can get a hold of some expired cast material and just practice casting other kids close to the same age that might be good temperament, and you can remove that cast right after. And it's a good way to practice, I think. A lot of times when you get kiddos that you are doing the restraint casting, they've gone through maybe a series of sometimes where we've put on limited restraints, a sock or a co-band or something like that. So hopefully as you get closer to possibly using it with a kiddo, that you can find out that family background, child background, and they're going to be a good candidate for it. But to answer your question, yes, if anybody would love to ever come and observe, we're always open for that.
One more question. Well, 2 little things. So I have done the co-band before, where I've just taken their hand and balled it up into a fist and co-banded their fist, which actually works pretty good. Then they didn't have to have their whole arm. But it ticks them off so bad. Have you ever had, because I did have this happen once, where anytime the kiddo saw the restraint device, like the co-band or even just the therapist, they start to flip out, and then your therapy just tanks and you get nothing. What's your approach to that?
I think Tara and Michelle would both agree, positive experiences in that shaping are crucial. Like Megan said, you're trying to make as much of this a positive experience, even though the child's having to go through a negative experience to get there with i.e. the casting. And whenever we get a family or a child that's going into this, we really heavily emphasize that those positive experiences need to take place. So whether that's the parents taking the time to make sure that child's successful with grasping or reaching or even hitting, we want that child to have those positive experiences so they can build on it. I've found that kiddos that tend to really do just, freak out, usually the first 24 hours is the worst. And once they kind of get the thought of, hey, this isn't coming off, I can't pull it off kind of a thing, and mom's not going to take it off, then time usually improves and they usually give into it a little bit and become more positive. If you're having a child that's screaming the second they see you or see the casting material or the restraint, I'd maybe back off for a little bit and give that child a little bit of time doing some other activities, being successful, and start from there and kind of work forward again. Sometimes you do have to kind of reboot and go backwards.
I would say we were very mindful of this little one's emotions as well as the family's emotions, and just really talking everybody through it and kind of use the same lingo every time, like, oh, wrap on, and just make it really basic. So she was starting to develop an understanding of what was happening. But we also had the family bring a favorite toy, lovey, like she had this little bunny that she loved, and she got to snuggle her bunny as we put the wrap on or the cast on, as well as food. It was a big motivator for her. So mom brought out a favorite treat that she could either snack on while casting or immediately after. So not just positive reinforcement with, activities with the cast on, but kind of during the process too. We made sure she was as comfortable as possible, because it was hard sometimes, but this little one did awesome. But she would get sad kind of initially, but like I said, we just let her know it's okay. We're walking her through it, and she did great.
we're not above bribery by any means. We'll use it.
I love the idea of letting her do something while she gets casted. I think maybe that would help. And working on frustration tolerance a little bit before. That's awesome. Thank you.
You're welcome. Sharice, yes, we'd love to cast your child's hand anytime. Sharice put a message in for those that didn't see it. I think she just directed it to me, but she said, can I pay you to cast my child's thumb? And we'd be happy to, Sharice. Sometimes we use it for thumb suckers, sometimes we use it for other things. So we'd love to.
Okay, it looks like Rebecca, you were coming off mute. Oh, we still can't hear you. So while
that's because I'm using my phone. That's because I'm using my phone for audio. Can you hear me now?
Yes.
Yep.
Okay, sorry. So I missed the very beginning because I was having some audio trouble. So I don't know, maybe you covered this, and I'm sorry if you did. So when I was in the clinic, I did a little bit of CM, was exploring it with the kiddo, and then I went to early intervention, so I haven't explored it as much. We used a IV mitt because one side was mesh, and so I wanted to be able to see the hand, and then we used some Coban to keep it on. And it worked well, and we called it his puppets, and we had little faces on it. But I was wondering, from the learn non-use, when you do a cast or a Coban or so many other things, you cover the entire hand. Do you think there is a benefit to actually like covering the whole hand, covering the elbows so they can't really use a lot of that arm? Or is that okay to have like kind of a more minimal restraint where they can see their hand and they can still like that, but they're not going to be able to do any of the kind of real functional things? Does that question make sense?
Yeah, I think it's going to depend on the individual child and the goals that you're trying to achieve with that child. It's all about neuroplasticity. So you're really looking at what does that child need long-term and what outcomes are you trying to achieve. If you got a child that's got great proximal control and strong shoulders, strong elbow, you might be working just on those distal skills, the grasp, the prehension, those type of things. And so using, you know, again, you're putting that restraint on the child's good arm to restrain them from using it and forcing them to use that weaker arm. So it's going to depend a lot on that function of the child in that weaker arm of what they've got and what you might prescribe to use. I sometimes with kiddos, because you are casting their good arm, and some kids are really good, even if you just leave their thumb out, they'll figure out ways of still manipulating things with their thumb. We've casted kids with everything covered, thumb, fingers, all the way up to the tip of their fingers, so they don't have anything to manipulate with. And some kids you have to go that far. So I think it just would really depend on what you're trying to achieve with that child long term.
Okay, yeah, I just didn't know if like visually, like it was a principle to make sure we were trying to cover the whole hand, or if it's okay if it's got that mesh on one side where we can see the hand, because I kind of liked that from a, you know, being able to look for breakdown if I've got it too tight, that sort of thing. So, okay, that was a good answer though.
Great.
What a great conversation. And we would love to have that continue. If you have any questions or suggestions or anything, please use the discussion board on our Canvas site. That's a great way to reach out to everybody. We are at time, so I want to be, you know, respectful of your time, and I won't want to keep you on here any longer. Next month, we are having Mary Beth Bruder from the Early Childhood Personnel Center come and talk to us about COVID and early interventions. So be sure to register for that. And don't forget to complete the survey so we can send out the certificate of attendance to you guys. And thank you so much for all that wonderful information.
Thank you. See you right later.